Hi, my name is Megan Ivester, and I am a DNP student at the Mercer University Georgia Baptist College of Nursing, and today I will be discussing von Willebrand disease. So von Willebrand disease is deficient or dysfunctional von Willebrand factor molecule, and essentially it's a bleeding disorder. And it can be either acquired or inherited, but it is a bleeding disorder. So the epidemiology of it is the most common inherited bleeding disorder, and it is significantly underdiagnosed in women and children because of the symptomatic portion of it. So this disease can present asymptomatically, and therefore there can be a lot of underdiagnosed cases that we see. So this picture basically shows the pathophysiology of it, that deficient or dysfunctional von Willebrand factor. So you'll see the endothelium, and you see the von Willebrand factor with factor VIII and the platelet, and it helps with platelet adhesion and clotting. And what happens in von Willebrands is you get excessive prolonged bleeding because you're not able to clot as well. And the von Willebrand factor can be presented in different ways as far as the dysfunction of it. And so that's kind of where the genetics comes into play. So we see three different types of von Willebrand disease. So it's either type 1, type 2, or type 3. Type 1 is going to be, type 1 and 2 are autosomal dominant, and the type 3 is going to be autosomal recessive or codominant. And basically with type 3, you're looking at issues with pregnancy and fetus. If both parents have the factor, then they're going to be more affected. However, it is a precautionary thing, more so in type 3 than any of the other types for prenatal screening and things like that. So, but what we're looking at is the von Willebrand factor is playing a part in all three of these types, just in different ways. And so the middle column is showing that in type 1, there's an insufficient amount of that factor. Type 2, there is an abnormal amount of that factor. And then type 3, there's an absent amount of the von Willebrand factor. And so that's kind of what makes it a little bit different than the other two types. But all together, the inheritance pattern, it can be autosomal dominant or recessive. And this just shows kind of that pattern as well. And we're looking at here on this side, it's going to be the dominant pattern. So you see it's pretty straightforward. This is more often how it presents, is the dominant, autosomal dominant. And then on the right, you're going to see the recessive. And this is not as common just because it takes two different changed genes to create this scenario over on the right. So more often it is autosomal dominant, which is on the left. However, it can be autosomal recessive as well, which is on the right. Risk factors. So as far as genetic, there is a strong family history component, and we're going to get into that in just a little bit, but the environmental risk factors, so things that can make von Willebrand worse or that can initially present with the bleeding disorders are going to be things like pregnancy, short-term physical exertion, inflammation, malignancy, hyperthyroid. Those are just a few. There is a laundry list of environmental risk factors. And then you get into the acquired von Willebrand disease, which is going to be more autoimmune diseases and things like that. So clinical presentation, the first part of the clinical presentation is going to be the clinical history, and this is a huge part just to gather information to arrive at your diagnosis of von Willebrand. So age of onset of bleeding is important because when you're looking at age of onset, that helps differentiate between congenital and acquired bleeding. Your pattern of bleeding, you're going to be looking at either mucocutaneous, which is your primary hemostatic defect, or soft tissue and articular hemorrhage, which is secondary hemostatic defect. So you're trying to differentiate between von Willebrand and your other hemolytic disorders. So those are two patterns of bleeding you're looking at, and then you're going to ask about surgery-related bleeding, and you're going to do a medication review to ask patient and family about antiplatelet agents such as aspirin and NSAIDs, so non-steroidal anti-inflammatory agents. The next part of that clinical presentation is going to be physical exam. And with the physical exam, the big point of it is you're looking for evidence of bleeding or anemia. This is a bleeding disorder, so you're looking for any evidence of bleeding that you see to try to narrow your focus. So easy bruising, epistaxis, gingival bleeding, menorrhagia, prolonged wound bleeding, post-surgical or post-dental procedures with prolonged bleeding after those procedures, and then gastrointestinal bleeding. Those are your hallmark signs that you're looking for to ask in your history and to look at your patient when they present in the office. So next part of clinical presentation is going to be your laboratory findings. So your initial assessment is going to be initial coagulation studies. So with your CBC, you are going to be looking for any evidence of microcytic anemia or low platelet counts. And you're going to do an APTT, and you're going to look at the PT, so prothrombin time. And with that, your PT a lot of times is going to be normal. Your APTT can be normal, or it can be prolonged with if you have a low factor VIII present. So the next laboratory, the next labs that you're going to do, it's going to be an initial von Willebrand disease assay. So it's going to be 3 assays, and the second one has 3 under it. So the 3 assays, the first one is going to be von Willebrand factor antigen. The second one is von Willebrand factor activity. And under that umbrella of the activity, you have your ristocetin cofactor activity, your von Willebrand factor immunoactivity, and the collagen binding assay. And then your third of the initial assays is the factor VIII clotting activity assay. So those are that's your initial panel that you're looking at after you get those coagulation studies back to see what results with that assay. The specialized assays that are listed under that, the von Willebrand factor multimers and the ristocetin-induced platelet aggregation, those are going to help you distinguish subtypes. So once you have any results from the initial assays, then when you want to start differentiating subtypes after that, then you can do more of the specialized assays. This chart just shows the difference in the types. You'll see on the left your different conditions with all the different types. Type 2 is broken down into 2A, 2B, 2M, and 2N. And from there, on the right, you have your different assay results and what you're going to see differentiating the different types. And in the middle, the description, that's just going to help differentiate those types as well. The diagnostic testing and screening. So there is a self-administered pediatric bleeding questionnaire, so the self-PBQ. And with this screening, it's a lot of times they're screening kids aged 8 to 12. The sensitivity is 83 and specificity is 79. So it's actually a pretty good screening tool that they're beginning to use. They're seeing it more beneficial right now in the hematology specialty clinics, just because they are more reliable for investigation of an inherited bleeding disorder versus other bleeding disorders. So it's kind of helping with that family history component and kind of bringing other pieces of information together when you're screening. They're still working on the primary care setting of screening for it. The biggest population they're seeing that this is beneficial for is adolescent females with menorrhagia. So a lot of females that initially that have puberty to begin with, and their cycles are lasting 21 days, they're bleeding 21 days in a row, and they don't realize that that is normal. That's what these screenings and these questionnaires kind of help bridge the gap and pick up in between, is to identify these patients earlier on that are having prolonged bleeding and to try to prevent and stop that bleeding earlier on at an earlier age. So as far as genetic testing for screening, it's not an initial screening test that's done. Genetic testing can aid in confirming diagnosis. but it's definitely not a diagnostic test for von Willebrand itself. Now, type 1 and type 3, it does not affect routine clinical management. Genetic testing does not affect the management. However, it is important to do because with type 2, it's pretty beneficial because desmopressin is, we'll talk about that in a little bit, but that's one of the go-to treatments. And actually in the type 2B for von Willebrand, desmopressin can worsen the thrombocytopenia that's present with that type. So it is important to do follow-up testing as far as genetics with the presence of von Willebrand in general. So as far as genetic testing and counseling, it's always advised with von Willebrand. It's, like I said, just more follow-up. So, and family members of people diagnosed with von Willebrand should be tested even if they're asymptomatic, because of a lot of mild cases of von Willebrand can present asymptomatic with no bleeding until they have a procedure of some sort, or pregnancy, childbirth, something happens and they have prolonged bleeding, and then you're trying to play catch up from the bleeding instead of being able to prevent and use prophylaxis. So what they would do with the genetic testing is it's a DNA test to delineate this mutation. And so they just do DNA testing to see, to differentiate the types that they have. And they're looking at polymers and probars and things like that. So you're really looking at determining the carrier status as well, just because a lot of times if you can do the testing and be screened and look at things prior to pregnancy, that just gives people more information as far as knowing what to expect or preventing complications in childbirth, and just preventing complications prior to procedures and things like that anyway. So it helps prepare for things. So as far as the treatment, the goal of treatment for von Willebrand disease, with it being a bleeding disorder, the goal is cessation of bleeding or prophylaxis for surgical procedures in order to prevent a bleeding episode from beginning. So the fundamental way that treatment works is elevating the von Willebrand factor. And there's 3 different ways that you can do that. And these 3 different treatments are not mutually exclusive. So a lot of patients can receive 1 or 3 at a time. It just kind of depends on their type based on their test results and the way they present and their hemostatic challenge and all of that. So the first one is desmopressin, DDAVP, and that increases the plasma concentration of VWF by releasing endogenous VWF stores through the stimulation of endothelial cells. So factor production, that just replaces the factor itself. So factor products, that's going to replace the von Willebrand factor by using human plasma-derived viral inactivated concentrates. And the third one is going to be the hemostasis agents. So these are agents that promote hemostasis and wound healing, but do not substantially alter the plasma concentration of the factor. So work in 3 different ways, and you can use 1 or 3. Kind of depends on their disease. So as far as education, you want to educate your patient that long-term prophylaxis is rarely required. So it's not a lifelong treatment necessarily, as far as it being a consistent treatment, but it is something that always has to be taken into account when things are being done. So another thing, you want to educate your patient to avoid aspirins, NSAIDs, platelet inhibiting drugs. Oral contraceptives for the menorrhagia, that's usually the recommended course of treatment, the medication for patients that are presenting with this ongoing bleeding in order to prevent those cycles from lasting so long. Monitoring and prophylaxis, especially for those surgical procedures in childbirth, like I discussed earlier. And then patients over age 2 may need to make sure that they have the Hep A and B, hepatitis A and B immunizations. As far as clinical practice guidelines, these are just 2 examples. Actually, the fundamental one is really the one on the left, the National Heart, Lung, and Blood Institute. The one on the right, the American Society of Hematology, derived all of their recommendations and their clinical practice guidelines from the National Heart, Lung, and Blood Institute. That's really the concrete guideline at this moment that is in place for the diagnosis and treatment, and they have some great algorithms and everything on their site as far as when a patient presents, kind of what to go through and what steps to take for diagnostic testing and treatment. And this is the resources for patients and families. And this top one, the top two are family education and genetic information. So the good thing about just the resources that are available for this disease is they understand that genetics does play a pretty big part in this. And so they went ahead and put in, genetic information within these two huge organizations for patients to review as they're learning about the disease and everything else. So it's great that we're, kind of putting it side by side as far as the family education and, genetic information as far as education for the entire family and getting screened. So the third one is Kids Health. That's a family education and child education website. It's got some good resources that are kid-friendly that children can read, and that will help them understand if they are diagnosed at an earlier age. And then the last one is just, it's more so fine-tuned to genetic testing and understanding genetic conditions and testing and things like that. So that's a great resource as well. So all in all, genetics plays a huge part in this disease and von Willebrand's itself. And there is extensive diagnostic testing that goes into it in order to specifically outline what type that they have of von Willebrand's, whether it's 1, 2, or 3. And that really helps and assist in navigating care for these patients when they do present with these symptoms that fall in the category of a bleeding disorder, but you're not really sure if it's inherited or what the nature of it is. So thank you for listening.